Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Today we have with us physiotherapist Chris Hahn. Chris, thanks for being with us today. Can you introduce who you are and what you do?
Thanks for having me, guys. I'm really excited for this. So I'm a physiotherapist and I've been working clinically for about 6 years. I originally actually trained as an occupational therapist, but decided to make a switch to the dark side, they say. So I went back and did my master's at Macquarie Uni here in Sydney. And I've been working in a private practice in an outpatient setting for those 6 years. And most of the clinical work that I did was in musculoskeletal and in sport. I kind of fell into the sporting side of things. But about 3 years into my clinical years, I decided I think it's time to go and do a bit of extra study. And I was throwing up between whether I do a master's in sport and exercise science or go through a PhD. And then after months and months of deliberating, I ended up doing a PhD. So I'm at the tail end of the PhD now, hoping to submit tonight, which would be good. And that's kind of how I've gotten to where I am today.
So can you describe what you've been studying and looking into in your PhD?
Yeah, so the main things we've been looking into are key issues in the diagnosis and treatment of low back pain. And so most of the work that I've done has been around how we can better diagnose low back pain, whether it's through imaging or clinical tests. There's not a lot of work in this space, so, and it's also a very controversial space, but it's been a really nice thing to dive into because it fits into what I do clinically day in, day out. So the biggest issue around diagnosis at the moment is that we currently can't really diagnose low back pain. And that's been the agenda for the last 10 to 20 years. But a shift is starting to happen now. I think more and more people are starting to get more interested in how we can better diagnose back pain. And so that's kind of where I've been doing most of my work.
Yeah, it's something that I think about where there's been a lot of research looking at the prevalence of certain spinal pathology in asymptomatic individuals, and it seems to be very, very high, which obviously brings into question how effective radiological imaging is for diagnosing the source of low back pain. Why is
Yep.
that? Why do we see such a high prevalence of quote unquote pathological changes in asymptomatic individuals? Are there any explanations for this?
Well, I think the study that we refer to is that Brindisi study. And I think a lot of clinicians quote that study around people who are asymptomatic also have pathological changes. But the issue with that study, and it's a fantastic study, but the only thing about that is it doesn't actually tell us the diagnostic cause of someone's pain. So that's a cross-sectional study. So it just shows us in a group of people here and now, what changes do they have in their lumbar spine. The one thing that we often forget, though, is although people who are asymptomatic also have anatomical changes, people who are symptomatic have a much higher prevalence. So, for example, when we look at disc degeneration, in that exact study, what we could see was about 56% of people with disc degeneration were symptomatic, but then there's only about 30% in the asymptomatic population. And so there's a big difference there, and we often forget that. And so there is something happening that people who are symptomatic often will more likely have those pathoanatomical changes. Now, it doesn't mean that we ignore the findings in the asymptomatic population, but there's definitely something to explore in those who are symptomatic. The reason why they have them, we don't know, but for example, with disc degeneration, again, we know they're most likely age-related changes. But again, what a lot of studies don't dive into is what about the severity of disc degeneration? We often say that people have it or they don't, but someone might have a low-grade disc degeneration, or someone may have a really high grade. And so when we look at studies, if you just clump everyone together, you're almost just going to get an average. It's like you've got people with high amounts of pain and people with low amounts of pain. You clump them all together, you kind of get an average score. And that's sort of what they've done in these imaging studies. So a lot of what we've tried to do is, with the data that's available, is to try and actually break that up a little bit and do more severe imaging findings. Are they more likely to be found in more symptomatic people?
Yeah, with that in mind, Chris, I know you work clinically as well, um, and your interest in doing this was thinking about how it can improve your what you do clinically. How has some of the findings from your research assisted, particularly like, well, focusing specifically on imaging,
Mm.
helped assist in your ability to diagnose and manage low back pain? Are there any particular things that you've changed or refined with understanding how you interpret imaging with people that present with back pain?
I think the short answer to the question is no, because I think a lot of the research that I've done is purely for research purposes at the moment. It's
Mm.
not ready for clinical application, and I think that's the biggest and most important takeaway. Is even though a lot of the studies that I've done have found that we can start to think about diagnosing low back pain, which I'm sure we'll dive into today, it's not clinically it's not ready for clinical practice. And the reason behind that is we need to actually know whether, if we diagnose someone with a particular cause of back pain, does that actually lead to better outcomes for the patient? And so we've got to be really careful before we start to implement these diagnostic labels. Does it actually make a difference? And so we need to test that before we implement it clinically.
Mm.
But I think from everything that I've done, the one thing that I've probably changed in the way that I practice is my language around the imaging findings. We're often very cautious around how we explain the imaging findings to people. But I think to a degree, and again, we have to be very careful about this, but I think to a degree, we also have to acknowledge that they're there. And if it matches someone's clinical profile, I think ignoring it probably has a hindrance to someone's recovery, because it almost feels like they're being ignored. And so I think that's probably the biggest thing that's changed for me.
What specifically have you
Um,
changed in your language, Chris? Like what kind of things do you say now? If someone does have a scan done on their back and it shows that
mhm.
there's some sort of discogenic injury, what do you say to
Yeah,
them? Are you very forthright about it? Do you really change your language? Like how do you look at that?
yeah. Look, it's a good point. I think it depends on the patient in front of me. But for example, if someone comes in with a discogenic type presentation, so that typical kind of pain with flexion, pain with coughing, pain bending over, and they have severe disc degeneration in their spine, but the language that I'll sort of use is, we know that there are these imaging findings prevalent and they may be relevant to your pain, but it doesn't explain the whole picture, but it's something that we can't ignore. And so we don't quite 100% know yet how to treat this, but this is what I think we can do to kind of get you there. And then I just lay out a bit of a plan for them based on their impairments. So I
Mm.
guess in short, it doesn't hugely change what we do clinically yet, but I think we just need to start to think about, I guess, not going the other way and completely ignoring it and saying, well, guess what? 50% of people, 30% of people who are asymptomatic also have these findings. It's not important, because then the patient sort of feels unheard. So I think it's just about acknowledging those things. And that's been around for a long time. We've all kind of known that for a while.
I think the really hard thing with it is that, particularly the way in which Western medicine is designed, it's very much still, particularly in the musculoskeletal space, it's very much like a pathanatomical model. So
Yeah.
patients start to attach to these ideas, and I always find it interesting when you have someone come in and they've had back pain in the past, and
Yeah.
you say to them, "Do you currently have back pain?" And they say, "No, but I've got a disc bulge." And you're saying to them, "Okay, well, like,
Yeah.
how do you know that?" "Oh, I had a scan 8 years ago." And you're like, "Okay, well, maybe that's current, maybe it's not." Um, but they've attached themselves to tell, like, you might
Yeah.
be seeing them for their knee, for instance, and they say, "Oh, yeah, but previous injury history, I've got a disc bulge." And you say, "Okay, interesting. Like, I'll document that, but is that relevant that
Yeah.
as a current pathanatomical kind of presentation?"
And I think that's tough because we don't know. We don't know if it's relevant. But one of the studies that we looked at was whether imaging findings can predict future low back pain. And so if you have someone who's coming with a scan, let's just take that example. they were found to have a disc bulge 8 years ago. Disc bulge wasn't an MRI finding that we found was associated with future pain. Now, take that as you may, there was very little data in this paper. But I guess in the back of your mind, you can sort of be confident in that sense. But I do understand what you're saying. And it is really hard because we actually don't truly know which imaging findings will predict future back pain. But there are some that we're starting to think about. And there is enough data to say that, well, these might actually be relevant. But it doesn't mean that we don't. So they're modic changes. So modic changes type 1 and type 2. So type 1 modic changes is essentially when you start to get some bony edema through the vertebrae. Type 2 isn't often seen to be associated with pain in general, but type 2 modic changes is when you start to get some fatty infiltration into the disc or the vertebrae. And again, they're not often associated with pain. But disc degeneration was the big one. The grade of disc degeneration we're not sure of yet because there wasn't enough data. And then the other one was, sorry, I just got to find it. Yeah, sorry. And then the other one was nerve root irritation as well. So that was one that we found in people with current low back pain. If they had imaging findings of some form of nerve root irritation, that it may predict future pain as well. But the follow-up of that was quite little. So we're talking in the short term, only about 3 months.
I think the other challenge with this too, with imaging, is you can educate patients as much as you want, but a lot of people do still really love to attach to that pathology. And it can be a very difficult one. And sometimes I actually might even like show them a paper to go like, look at the prevalence of, say, disc degeneration in asymptomatic individuals, to say like, yes, it may be related to your current back pain, but it's actually not indicative of your outcome. You know, you might actually still have a good outcome with no back pain in the future, but still have indications of disc degeneration. But it's a very tricky one to create that behavioral change.
The one that I always refer to with people is, what's the paper that is about disc reabsorption and over time?
Yes. Yep. Yeah.
I can't remember who the authors were, but essentially, like I often like to talk to people about that and say, you know, there actually is quite strong evidence that over time, even if you do have something like a disc protrusion, that there will be some form of resolution. And so just because these changes right now are very relevant, it doesn't mean that your body won't, over time actually reabsorb that and you will have a better outcome even in the actual pathology itself of what it presents.
Well, actually, the other one I think of too is there seems to be some evidence supporting running to improve your disc height as well. So have you come across that research, Chris?
Yeah, and just referring to that absorption of the disc herniation, I think in that study too, they found that if you had the bigger the herniation or the bigger the bulge, the more likely it was going to reabsorb. And that's quite positive.
Yeah.
In terms of running, there is actually a really nice study that's being published soon. That was presented at a conference I was at, but it's for people with chronic low back pain, and they participate in a running program. And we know that some form of resistance and some form of loading seems to actually be quite beneficial for the disc.
Yeah,
that's the way we should.
Go on, Chris.
Sorry, I was just going to say, the way I think we should think about that, though, is we know that degenerative changes quite like load. So when we look at, for example, arthritis in the knee, we know that some form of impact and some form of running actually has a protective effect. It actually helps thicken the hyaline cartilage around the knee, and it's quite positive for people with arthritis. The back is no different. You know, disc degeneration is almost just a form of arthritis in the spine. And so it clinically makes sense, but we then are so afraid to implement what we see in other parts of the body into the lumbar spine space. And we are starting to see that now with these trials, just like this running trial. And it's fantastic that we're moving that way, that we're starting to look at pathology and go, well, what form of exercise can we do to try and elicit some changes? But more importantly, does that then improve their outcomes? So yes, their disc height might improve, but does that reduce their low back pain? And I think that's the next kind of step as well.
Do you think that's a sociocultural overlay? The fact that people are so fearful of back pain and back pathology as opposed to, say, some sort of peripheral, injury? I always use the
Oh,
analogy of
definitely.
people, you can roll your ankle really, really badly and it's really uncomfortable to walk on, and it might be, 7 out of 10 pain or whatever it is. Yet
Mm,
people don't seem to have the same psychological fear associated with
that's
their
right.
ankle and returning, say, to activity that they do if they've hurt their back and the pain 7 out of 10 with sort of mechanical tasks.
Yeah. And they'll almost say to you, can I play sport tomorrow? Am I okay to play? They're almost willing to go and do more activity even though they've rolled their ankle. But for the back, it's the opposite. And I think there's definitely that cultural thing that you've mentioned. But it also comes from other health professionals. And so, just this morning I had a patient with back pain and they were told to never bend over from their GP.
Yeah,
And I just think it's
it's
crazy to think
dangerous.
that we're still giving that kind of advice. Exactly. And, one
Yeah.
of the, and all I said to them was, well, you're sitting in a chair at the moment. Technically you're bending over, but it's just a dangerous thing to do. And I agree. I think we're seeing less and less of that, but unfortunately it is still happening in the community.
The other big thing too is you mentioned before, joints respond to load, and how much of the
Mm,
issue with, for instance, degenerative changes in the back is due to underuse. Because the reality is the general population is sedentary, and there are obviously other lifestyle factors associated with poorer health, including our musculoskeletal system. But part of the issue is providing appropriate loading with an appropriate timeline to see positive changes potentially in the integrity of the tissue. Then, obviously, hopefully, too, an improvement in their symptoms as well if it is associated with those degenerative changes.
yeah, and you've touched on such an important point. Is we often associate degenerative changes, arthritis, to people who are overactive,
Mm.
but often the people who are affected the most by these conditions are people who are sedentary and have comorbidities. And when we look at studies around, for example, people with obesity, people who have a high BMI are more likely to have arthritic changes in the CMC joint of their thumb, and that kind of doesn't really and that's compared to people with a lower BMI. And you kind of think, well, what's going on there? And there has to be some kind of systemic contribution to that, whether they're in a highly inflammatory state. Because we know arthritis now is more an inflammatory condition, even though even osteoarthritis is a highly inflammatory condition.
Mm.
And so you make a really good point, and I often wonder if there definitely is a threshold that if you're too active, then you're more likely to develop arthritic changes. But then are those arthritic changes going to be symptomatic? And that's something we're not 100% sure about yet. But I do think we need to change that perception. And I agree, we need to get people more active. And I often wonder if people were more active, would they have less symptomatic arthritis or less symptomatic discogenic pain?
Mm. Yeah, and I think that's important to make that differentiation with chronic type conditions where it could be associated with overuse, or say like you've had prior trauma to a particular joint, but obviously for the
Mm,
majority of people that isn't the case. So making that differentiation is important to understand for the individual, that less isn't necessarily better, or that idea of like you're just further degenerating the tissue by applying mechanical load.
mm,
uh, the other part of the equation with undiagnosing low back pain is clinical assessment. And like you mentioned before, I think with, say, disc pathology, of whether it fits in
mhm.
with a clinical picture of, say, for instance, pain with flexion, coughing, and so on. Is there research to support that we can be confident with using certain clinical measures, both subjective and objective measures, to be able to diagnose the source of low back pain, for instance, with discogenic pain?
There is some research emerging now. So recently, we published a systematic review looking at exactly that. What clinical tests can we use to identify a potential source of back pain? And the three sources that we looked at were the disc, the SIJ, and the facet joint. Unfortunately, these studies are limited by whatever data is currently available. But what we did find for the disc was if someone had the centralization phenomenon, so for example, if they have low back pain plus lower limb pain, if repeated movements of the lumbar spine centralize the peripheral pain, then you can be quite confident that the source of their low back pain is coming from the disc. But that was the only clinical test that had good data on it for the disc. When we looked at the SIJ, if you had 3 or more positive SIJ tests, then you could be confident that their source of low back pain was coming from the SIJ. And unfortunately for the facet joint, there wasn't any clinical tests. The rest of the tests that we found that were informative or useful were actually all MRI or imaging based. And again, we have to be very careful with how we interpret that. But unfortunately, there's just not a lot of data out there around the clinical examination perspective of it. I think what I would really like to see, though, is a lot of research looks at these tests individually, but as we all know as clinicians, we never diagnose someone based on one test. It's always a combination of components of their subjective history, components of their clinical examination. And it would be nice to one day form, a bit of a clinical prediction rule or a clinical test that is a cluster of tests that we could use to anything to do with the lumbar spine.
Just describing what clinical tests are valid makes you a bit concerned in the sense that there's actually not a lot of confidence in some of the testing that is commonly used clinically. And you said for the facet joint, there actually aren't any clinical tests that were indicated as being of good, specificity, sensitivity from your systematic review. But if you were to look at individual papers included in your systematic review, do you start to see that although the systematic review itself didn't find confidence with other tests, that there are indications from individual studies included that we may use some of the other commonly used tests clinically to improve our confidence with certain types of low back pain presentations?
Definitely. And when we look at, for example, the facet joint, although there were no clinical tests that we could do an analysis on, the common theme is any extension-based activity in the subjective history. So, for example, prolonged walking or prolonged standing, or lumbar extension or that lumbar quadrant. They were somewhat indicative. But again, we're looking at individual studies, and some individual studies may say that they're relevant, and then the other half say they don't. And so that's kind of half the problem, is we're basing it off single studies, which we shouldn't do. That's not the good way to do it. But in saying that, we almost need to take into consideration these single studies, especially if they're of good quality, because although we may not use it as gospel, it just helps us guide how we can potentially diagnose someone, because it's going to change how we treat them. If someone presents with a very facety type presentation, well, I may not, the way I do my manual therapy may change a little bit compared to someone who's got a discogenic type presentation. The same thing was for the...
Sorry, go, Chris.
Yeah, sorry, I'll let you go.
Oh, no,
you go.
Well, this brings up a really interesting point, because I think of research for what we do, there are just so many gaps in our knowledge from a research perspective in terms of validating what does or doesn't work clinically. But part of our role, it seems, is to fill in some of those gaps. Because something else that you mentioned, for instance, is using manual therapy, which, don't get me wrong, I use manual therapy a lot. But it seems that you get certain academics suggesting that, well, there is no support or evidence for manual therapy, for instance, for something like low back pain, even though clearly a lot of clinicians find it very useful. And I'm interested to hear from your perspective, now you're obviously just about to complete your PhD, you're obviously very involved in understanding research, but how you actually think about applying research into clinical settings, because honestly, I feel like that's quite poorly done a lot of the times when you have researchers presenting their work or thinking about how that fits in with the overall bigger picture, because a lot of things that we may do in the real world may not be reflective of a systematic review supporting it, even though we find it's clinically valuable.
Oh, you're going to get me in trouble, Jack. And this has been one of my big points is at the moment, I think in physiotherapy, we're the most segregated profession I've ever come across. We
Mm.
have researchers, we have clinicians, and we stand on the complete opposite end of the spectrum. And we need to come together. And so the way I kind of think about it is that I remember back at uni many years ago now, there was that the three circles, and there's that overlapping part in the middle. And so one was clinical expertise or clinical experience, the other one was patient expectations, and then the other circle was research. And it's about blending the three together. I think, firstly, the reason why a lot of the research that we've done, it always comes down to an agenda. And so, for example, if we look at diagnosis in low back pain, it doesn't fit the current agenda at the moment with the way we're going in the back pain field. And so it's quite challenging to get these papers across, and it's quite challenging to get funding sometimes. The other thing too is there's almost been a bit of a misinterpretation of the research as well. So when we look at manual therapy, we often say, well, manual therapy is not effective for low back pain. But we've got to be very careful and think about, well, what population are we talking about? Because for people with chronic low back pain, it's 100% correct. Manual therapy isn't very useful. It's no better than exercise. It's no better than any pharmacological treatment. But when we think about people in the acute and subacute phase, manual therapy is actually quite effective. And the effect sizes for manual therapy is actually a lot higher than it is for exercise as a treatment for acute back pain. But we don't talk about that. We only talk about what fits the current agenda. And that's not an attack or a shot at researchers. You know, I'm one of them. But I just think we need to be really careful with how we interpret the message. But then we also need to be just as careful in how we get that message out. Because unfortunately, a lot of young and new graduate physiotherapists will kind of hear that and say, well, manual therapy is not effective for chronic low back pain. But then they'll go and apply that to people in the acute phase as well.
Mm.
And I think that can be quite dangerous for the patient.
Chris, why do you think that there's been that change? Because what you're describing there is evidence-based practice model that was put forward by David Sackett, I think in 92 or 96, I can't remember. So why do you think that evidence-based practice has morphed so much away from what is clinically relevant and even the expectations of the patient much more towards weighting research? Because the initial proposal that he put forward in the 90s was one in which they were equally weighted to be able to be used. It isn't one where research is worth 90% of the input or the approach that you should take. So what, you know, for someone who's been on both sides of the fence, why do you think that that's the case and that's shifted in that direction? Because you're 100% right. Young clinicians will say, oh, there's no evidence for that. And you're like, well, that's only really, if you want to be evidence-based, then that's a third of the equation.
Right.
And I was just going to just add to that too, John. The other thing I see, and you highlighted this, Chris, is how nuanced the question you're asking. Because if you say, is manual therapy effective for low back pain? It's such a vague question to ask. You haven't given any clear indication of like the type of low back pain presentation and what contributing factors there are, let alone the actual manual therapy technique. Because and you sort of alluded to that before with, for instance, treating a facet joint type of presentation versus a disc type of presentation. So I feel like there isn't enough nuance in the kind of questions people ask to be able to come to a clear answer of whether a particular treatment modality would be appropriate or not appropriate.
Yeah, it's such a good point. And I really struggle with this question because I never know how to answer it. But I think there's, you know, I may offend a few people saying this, but and the reason I'm willing to say it is because I think providing patients with the best care is the most important thing for me, is that I think we get stuck into our own biases too much. And I think also, I often wonder, do physiotherapists, let's just take manual therapy as an example, are they performing manual therapy without the clinical reasoning and not getting the result they expected? So for example, if we have someone who presents with a really facety type pain and they don't really like extension, but then as a young clinician, we get them face down on the bed in an extended position, then we mob them further into extension and they get up and they're worse off. We go, well, yeah, that kind of fits my bias in the research that manual therapy doesn't work. But what if we got that patient sideline? Or what if we put them in a little bit of lumbar flexion instead? And so I wonder if kind of the technique around when and how to apply manual therapy hasn't been taught well enough, or maybe there's a mismatch in what's being taught at uni versus what's being taught clinically. I mean, I went to Macquarie Uni for my postgrad and I thought it was fantastic. They really painted the picture around, if you're going to use manual therapy, that's fine, but you just need to make sure it's your clinical reasoning is there with it. So that's kind of one thing that I often think about. And again, I don't mean to offend any universities or any new graduate or young physios, but that's what I tend to see in clinical practice sometimes. And then from a research perspective and an academic perspective, and again, not to offend anyone, but we're always going to promote what we believe is to be true based on the research that we've done. So you guys talking to me, I'm open and happy to talk about diagnosing back pain, but a lot of people aren't open to that conversation. And so at university levels, you've got lecturers and researchers who are presenting a lot of the work that they've done or what their colleagues have done. And you may not necessarily, I can't imagine my work being presented at a university level at the moment because it just doesn't fit the agenda. And so I just wonder if maybe there's that little bit of nuance there, and then that gets filtered down to the young physios and so on. And eventually that comes down to the patient, and the patient doesn't get the best care that they maybe possibly could have gotten.
Yeah, look, I think you highlight a really couple of important points, and the reality is we do all have our bias, and I mean, research can be done, or researchers can have their own bias as well. I think the other big one though too is, like, within our profession, and within Australia, there is a certain meta narrative. Like, there is a certain kind of message of, this is what we do as physiotherapists within musculoskeletal physiotherapy. And particularly as a student, or even for a lot of clinicians, if you're not exposed to other thoughts or ideas, you don't start to realize some of the embedded beliefs and biases that we have because we're indoctrinated into that way of thinking. And it's interesting. Like, I do some work at Lateral University, and the fourth year physiotherapy students in the undergraduate program just finished. And I know quite a lot of them, and I was speaking to them last week, and I actually mentioned that to them just to say, like, just understand that there is a lot of different ideas and opinions about how things are done and how things are treated outside of what you've been taught or what you think. And they kind of looked at me a bit funny, like a bit like, oh, really? Because I guess for them, they kind of think of it as it's very black and white. If someone's got discogenic low back pain, here's the gold standard, we follow that. If they've got a tendinopathy, here's the gold standard, we follow that, without realizing actually the reality is a lot of people have differing ideas, and that actually starts to expand outside of Australia too. Like, that's something I'm currently involved in a training program overseas where I'm working a lot with physiotherapists around the world, and they have very different training, a lot of them.
Yeah. And it's also very confusing for university level physios because you have all this conflicting evidence. Diagnosis isn't important. Oh, wait, a diagnosis is important. One study shows something's appropriate, another study shows it doesn't. And so as a young clinician, there's a lot of white noise and it gets really confusing. And so you almost, if you're not careful, you kind of fall into what's comfortable for you. And sometimes we get sort of stuck in our ways and we don't recognize our own bias. And yeah, so it is a really challenging space. We're not pointing the finger at anyone, but I think the days of learning different skills and applying which ones are relevant to our patient, I feel like those days are slowly slipping away. We learnt the McKenzie method, the Maitland method, the Mulligan method, the CFT approach, the psychosocial approach. One does not fit all for all patients, obviously. And for some patients, a little bit of McKenzie, a little bit of the CFT, a little bit of this, that kind of helps their whole treatment plan. But we seem to want to silo patients into a particular model. And if they don't fit that model, well, then, it must be their fault that they're not getting better, So we kind of just, I think we need to broaden our horizons a little bit.
The other thing with low back pain is 80% of low back pain can be classified as non-specific. What's going on there? Why is it that the majority of back pain is given this label, and is the label of non-specific low back pain useful clinically, both for us as clinicians, but also for patients?
Yeah, when you look back, I wrote a editorial on this exact thing, and when you look back in time, when the term non-specific was first founded, it was in the 1950s, and it was used as a term purely as a placeholder. And so physicians used the term non-specific low back pain for people where they couldn't diagnose someone's source of pain through clinical tests or through imaging. And their intention was always for us to explore this further. But for some reason, the term non-specific low back pain, rather than being a triaging term, which is what it was intended for, ended up becoming a diagnostic label. And the term non-specific low back pain, if we really think about it, it doesn't really help guide us. So I think as a triaging term, I think it's fantastic, because as a clinician, I can say, well, this person's low back pain isn't due to a serious or a specific cause, but it's due to something non-specific. But then within that, I still want to try and subcategorize or subgroup or whatever term you want to use, but we still want to break that up a little bit. So within the umbrella of non-specific, is it discogenic? Is it a facet? Is it muscular? Is it whatever else it might be? And I just don't think the term non-specific low back pain as a diagnostic term, it doesn't add any value. And when we think about non-specific low back pain, if you research something that has a non-specific label, then by nature, the treatments are going to also be non-specific. And we see that now in the clinical guidelines. Clinical guidelines don't help us individualize treatment. It doesn't tell us how much exercise that someone needs for what condition they have. It doesn't tell us what medications they should take and for what specific medication they should take for a specific cause. And so it's quite general advice. And I get for the majority of people, it doesn't make a difference, because through natural history, the majority of people with back pain will get better. But there are a big proportion of people with non-specific low back pain who don't.
Mm. The thing I think of too is, I know there's been a lot of research and discussion around, say, terminology and language and diagnoses used, because people may have certain connotations associated with a word or a diagnosis. But at the same time too, I don't think it's useful at all clinically to give someone a term non-specific low back pain, because even just with developing a demonstration of your professional knowledge, it's very, no pun intended, non-specific. And people, people obviously build confidence in your ability based on your ability to demonstrate an understanding of exactly what's going on. And so it's something that I get concerned with if it's used as a diagnosis. But as you mentioned, that actually wasn't the point of it to begin with. The other question I have then related to that is, the current diagnosis for low back pain is related more to intraarticular pathology, but it seems that a lot of low back pain is not related to the disc or the facet or the SIJ, that it's more extraarticular. Are we starting to build more knowledge and understanding about being able to diagnose different types of low back pain and have particular clinical or radiological assessment to confirm that?
I actually think we're going the other way. And so when I think about, and correct me if I'm wrong or if I've misinterpreted your question, but when we talk about extraarticular, we're talking about potentially muscular or ligament causes. Is that kind of what you're referring to?
Yeah, no, definitely, like muscular ligament, fascia type tissue, all the
Yeah.
above, yes.
So when we look at work around, for example, Paul Hodges, he's been a massive leader in the field around what's the role of transverse abdominis and multifidus and all those muscles and low back, and what's their association with low back pain. But time and time again, we've found that changes within those tissues, like whether it's width or thickness or endurance measures, we haven't really seen that improvements in those factors have led to better outcomes or a reduction in pain and disability. And so I think that's why we've almost moved away from that a little bit and moved a little bit more towards something specific. But it doesn't mean that it's not relevant. I think one of the big issues with trials like this that look at, trials in general that look at muscular changes is we get a group of people with low back pain and we clump them all together. And so some people will already have quite big and thick multifidus muscles, whereas other people may not. And then we present an average. Whereas I think what we probably need to do is we actually need to almost run a sensitivity analysis, and we need to look at, and we need to separate them. We need to group them as, what about people with really strong multifidus muscles or really thick and dense multifidus muscles on imaging versus people without? And they're just the people with back pain that we're talking about. But what about people without low back pain? And how do they compare if they've got, again, a subgroup that have really strong and thick multifidus muscles versus those who don't? So there's almost these 4 groups that you want to look at. And I think we haven't really looked at it properly. And in the studies that have, we haven't found a lot. And so, yeah, it's interesting. I was talking to a physio about this the other day, and when we talk about transverse abdominis, multifidus, and all those muscles and extraarticular causes of back pain, the first thing is, how do we truly measure it? I don't know how we measure it, because I'm sure the fascial sling has a big part in it. But objectively, from a scientific perspective, we probably don't really know how to measure it. And that might be why we haven't done any more research in that space. But then the language around that as well the language around that is also important, because we kind of had this huge trend for 25 years around, we need to have good transverse abdominis, good multifidus strength. But then we didn't really have a good objective way of measuring it. And so people were doing all these exercises, all these core exercises, but we couldn't actually measure whether they were getting better or not. Well, not effectively anyway. And then when their pain didn't improve, although they've done a 12-week program of deep abdominal strengthening, it kind of led down the route of, well, hang on, is my back unstable? And I think that's where fusion kind of fit in really nicely, because it's like, well, if my back's unstable and I've done all the exercises to try and stabilize, quote unquote, stabilize my spine, well, maybe a fusion is the only option. And we almost shot ourselves in the foot a little bit. And so I think that's why researchers are probably a little bit hesitant to move into that space.
Yeah, it's interesting you mention Paul Hodges, because I think of some of his more recent research, and look, these are only in animal models, so there's a lot more work to be done. But looking at, say, some of the changes within the fascia of the erector spinae, like the multifidus, following a disc lesion, where you start to see changes in more fibrotic tissue formation that is associated with poor outcomes long term. And I think of, say, I don't know if you've ever seen any of Ellen Langevin research. She published quite a interesting paper in 2012 of looking at changes in the shear strain of the thoracolumbar fascia with individuals with chronic low back pain. And maybe some of these changes, for instance, with Paul Hodges' research of looking at changes in the fibrotic changes in the fascia of the erector spinae, that happens following a disc lesion. So maybe it's a secondary problem to that. But then I think of, say, changes in the shear strain of the thoracolumbar fascia, where it builds an increase of passive stiffness. You get a proliferation of things like myofibroblasts, so it starts to then alter the tension and therefore the potential for nociception in that tissue. And that's where my interest starts to come in of, do we need to stop focusing on always thinking of it being intraarticular and think that there may be extraarticular sources? And if so, are we getting better at being able to diagnose that either clinically or radiologically? And then probably more importantly, what kind of interventions can actually restore some of the normal tissue mechanics at the fascia or muscular level?
And I think there was also some work around people with chronic low back pain in those muscle groups also had higher levels of fat infiltration. So it was almost that idea that these muscles were wasting away. And I completely agree. I think it's great. Paul Hodges has probably copped a little bit of slack for his research around, still pushing this agenda, but I think it's fantastic, because I think it really drives this new innovative thought process around how we can be better clinicians and better diagnose and that may lead to better treatment. If we come to a dead end and we realize, hey, this wasn't very useful, then we move on. But I agree with you. I think we need to look a little bit more outside of the the intraarticular. We've got the SIJ, the facet, the disc, but we need to start to think about other sources. And in my systematic reviews, I have a whole paragraph on that, and I talk about how we need to think a little bit more outside just these three structures, because we know there's more to it. But how do we actually run those studies? What testing measures do we use? What groups of people do we include? Do we only want to look at acute pain or do we want to look at chronic pain? So yeah, there's a lot of nuances, but I think it's a really interesting space.
Do you actually see more research being done where they're applying interventions to more specific subclassifications of low back pain? Because it seems that a lot of research that has been done is more about using this intervention for low back pain, but obviously the issue with that is it's not clear in terms of what particular problem they're trying to address. Do you see a change in how research has been done to be able to better support specific interventions for specific problems?
Yeah, we are starting to think about this a lot more. The problem is you need to have good diagnostic research in order to run those intervention trials. And so when we think about diagnostic studies, there's only 60 odd studies that look at how to diagnose back pain. Whereas when you look at interventions for low back pain, there's over 450 papers. And that's just for exercise. So there's this huge disparity. And so if we really want to think about how we can better develop specific treatments, we need to lay down that diagnostic research first.
Mm-hmm.
And that's where I'm hoping a lot of my work will just start to build a bit of that groundwork. But we are starting to see some really interesting work. So back in roughly 2010 to 2012, we saw the trials around antibiotics for low back pain. And that was controversial because everyone thought, well, hang on, we're gonna end up in a massive overprescribing and issue around this. But the theory was that in a subgroup of people with modic changes, the cause of their modic change was due to an infection, a specific type of bacterial infection. And so they gave a group of people antibiotics and found that people who got those antibiotics and had that specific infection got better outcomes. Now, the trial wasn't done well. There was a lot of bias and it could have been done better with the control group. But it just started to paint the idea that maybe we can start thinking about things a little bit more specifically. I know now we're looking at rerunning that. There's a group that's looking at rerunning that trial, and they're going to do it by having a good control group. And so that can help to answer those questions. But to answer your original question, yeah, we don't have a lot of research looking at, if we want to base a treatment off a specific pathology, there isn't any work. There is very little work. There's only one systematic review that was done, and it only included 8 studies. And what that study looked at was, do people with specific MRI findings, if they get a particular intervention, do they get better outcomes? And there was only 8 studies, and nothing could be pulled. There wasn't enough data, and a lot of those 8 studies, well, actually all of the 8 studies, their intention wasn't to answer that research question. They just tried to extract the data to try and answer the question.
Do you have any other questions you want to ask, John? No. A question we always like to ask our guest, Chris, is it's getting to know something else about you outside of your professional work. So is there anything that you are learning about or doing that's sparking your interest or curiosity?
Yeah, recently I've started to look into a little bit more of a leadership skills, and that's been a really interesting journey, kind of moving outside of, the last 3 or 4 years. All I've been doing is reading about the back and physio related things. So it's been nice to kind of step out of that and read a little bit more about leadership and how we can be better people. And then the other thing that I've taken a lot of interest of is running. So I've started running over the last few years and hoping to try and get to a half marathon next year, but we'll see how the body holds up. not getting any younger. But that's kind of where my main interests are at the moment. But I think that will change over the next couple of months once I get through this PhD.
Yeah, I imagine there'll be a big change in your work to life balance once you've actually got it fully done and submitted and accepted. All right, well, Chris, thank you very much for giving up some of your time to be with us today. It was great to hear about your research and your thoughts on this topic. It's certainly an area that, yeah, I mean, the reality is it seems like there's still a lot to be done in terms of really understanding how we best diagnose and treat low back pain. But it's great we've got people like you helping to try and answer that question.
No, thank you for having me. It's been really good, and I'm a big follower of your podcast. So thank you for all the content that you guys put out. I know it's a lot of work that's involved behind the scenes.
No, we appreciate having people like you on to contribute. So thank you.
Thank you very much.
Right.